the indications for starting treatment haven't changed recently, so we're still using those indications that we've used for many years, and those are progressive anemia, progressive thrombocytopenia, or disease-related symptoms that we want to go away and that are impacting on the patient's quality of life. So John Burke, maybe you can help us understand how you think about prognostic factors and how they're useful in terms of selecting first-line therapy. What are the things that you're thinking about when you're assessing a patient for and deciding on first-line therapy in terms of the prognostic factors?
Yeah, I mean, I think the prognostic factors, some of them we've already discussed, include you know, just kind of going through the CLL IPI, which looks at age. You know, the older the age of the patient, that's an adverse factor. The stage, of course, the more advanced the stage, the farther along the disease is. I look at the IGHV mutational status, which seems to be most important as a prognostic factor with chemotherapy. And by FISH, look at deletion 17p and other you know, chromosomal abnormalities on the FISH panel. And then on the next gen sequencing panel, you know, the TP53 mutation and other you know, mutations like Burke3, SF3B1, and Notch mutations. So those are things I kind of look at. You know, there is this formal CLL IPI score that one can calculate. I confess I don't often actually do the math, but I sort of look at those factors when I'm thinking through a patient and his or her prognosis.
So in terms of thinking about options for first-line therapy, we have, for first-line therapy, we've had for many years now chemoimmunotherapy. We have BTK inhibitor-based therapy. We have BCL2 inhibitor-based therapy. So help me understand a little bit about how you select which treatment you're going to use, because we know, and we've known for many years, that agents work best agents that work best in the frontline setting. So the response rates with a BTK inhibitor are going to be higher, and the progression-free is going to be, survival is going to be longer for a BTK inhibitor, for example, when used in the frontline setting compared to the relapse setting. So selection and choice of first-line therapy is an important decision to make for patients. And we have options, and we have a lot of data to support what our decisions are, and we have differing opinions in terms of how to prioritize and how to select frontline therapy. So maybe John Burke will start with you, and maybe you can just sort of highlight what are the factors that you think about that help you select for a BTK inhibitor versus a BCL2 inhibitor versus chemoimmunotherapy.
Yeah, so I would say for most patients, the choice comes down to a BTK inhibitor versus you know, BCL2 inhibitor, venetoclax, obinutuzumab combination. The exception where it becomes even more complicated, I would say, is the younger fit patients who have favorable risk factors, that is mutated IGHV and lack of any adverse factors on FISH and lack of a 17p deletion and TP53 aberrancy. You know, I think the reason for that is that group of patients seems to have a particularly good outcome with FCR chemotherapy, and as you and your group have shown, you know, really potential for significant percentage of those patients treated with FCR to continue to be disease-free well beyond 10 years now. And so that's a group that seems to get particular benefit from the FCR regimen. So in that group, I think the FCR regimen or something similar to that still comes into play as an option. For most everyone else, the choice in my mind is probably going to be a BTK inhibitor versus venetoclax obinutuzumab. And then, you know, how do you choose between those? You know, honestly, it doesn't have as much to, you know, to do for me with disease, the biology, the gene mutation, et cetera. A lot of it comes down to other factors related to the patient and the patient's preferences. For example, venetoclax obinutuzumab is a 1-year fixed duration therapy. That's a big difference from indefinite therapy with a BTK inhibitor. So that fact of the different duration of therapy really comes into play in that discussion. Other factors like the presence of underlying cardiac disease, atrial fibrillation, or use of an anticoagulation therapy really is going to sort of knock BTK inhibitors a little bit to the side because of their toxicity profile, and that's going to help make the decision. A lot of it, for the patient who doesn't have the obvious contraindication, comes down for me to patient preference. And so as Dr. Shadman said, it's really sort of a long conversation over a period of many visits, often weeks or months, and sort of sorting out what's going to work for that individual patient. So that's how I approach it.
So highly individualized, and it sounds like you engage the patient quite a bit in the decision. And
absolutely, yes.